First, we would like to tackle the question, what is goal attainment scaling? Throughout the presentation, we will be referring to goal attainment scaling by its acronym GAS. We will interchangeably use GAS and goal attainment scaling. So what is goal attainment scaling? It's a technique used to evaluate functional goal attainment. It can help document how a client progresses over time. A goal is made for a client, then a clinician makes 2 objectives that are more than anticipated and 2 that are less than anticipated. Most unfavorable treatment outcome is -2, less than expected success is -1, expected level of success or the actual goal is 0, more than anticipated success is 1, and best anticipated success is labeled as 2. These classifications are denoted on the slide. This is referred to as a process of scaling goals. The clinician can combine all the scores from multiple goals to get an overall goal attainment score. This process will be talked about later in the course. GAS was developed by Kirasuk and Sherman in 1968 because they wanted a better way to measure change with their clients. They worked with people in the mental health population. They found using GAS, it was a better way to document change and could help them in constructing their abstract goals. When this article was published, Kirasuk and Sherman advised that goals be weighted. Example, more important goals with more weight. But later in 1994, they advised that with the new statistical methods, the weighting system was no longer needed. In 1979, Sitcherbaum and colleagues conducted a literature review in GAS. At this time, GAS was considered the most popular outcome evaluation technique in the human sciences. It wasn't until 1983, when Clark and Caudry introduced GAS into the rehabilitation world, that occupational therapists, physical therapists, and speech therapists started using it in their practice. As you can see, researchers have defined what the -2 to +2 objectives means. This shows that there is not one uniform way to scale goals, according to the literature. The column farthest to the right is what the creators of GAS intended each level to be. But as you can see, there are other people who have made their own definitions that are similar to the original definitions. But for purposes of this course, we will use King's scaling method with baseline equaling 0. This is the column that is the second to the right. This will make goal setting more clear for this course. This slide gives examples of how Kirasuk and Sherman scaled goals. In this example, there are 5 different goals that they are using for one client. They have scaled each goal accordingly. The person selected was in the mental health population. In the example that Kirasuk and Sherman picked, you can see that there are weights placed on the goals. As was explained earlier, this is no longer needed. Just take a quick look at the goals and the even intervals between the goals. This is a brief introduction of how the creators of GAS intended for the goals to be scaled. There have been many populations that GAS has been used with to document change. Just to name a few would be the community-based health promotion, cognitive rehabilitation, acquired brain injury, health promotion, early intervention, the geriatric population, physical therapy, occupational therapy, and speech therapy. Later in this course, you will see how different populations can be used with goal attainment scaling. Carol Conway will be providing her feedback throughout this course. She is an OT in the schools who would love to start utilizing GAS in her practice. She taught a guest lecture about GAS in a course at Cleveland State University's Occupational Therapy program. I'll let her introduce herself.
Hi, I'm Carol Conway. I'm a pediatric occupational therapist who works in the school district in Hudson City Schools. I have been an occupational therapist for 33 years. I've been in the schools for the past 24 years, and prior to that, I worked in outpatient rehab in pediatrics. and I have a master's degree in psychology.
We also asked Carol, do you see GIS being useful for all populations you work with?
I think I could really use it with all my clients in school-based practice because it correlates so closely to an IEP objective, and the IEP objective, of course, is legislative, and I need to do it that way. But I need to measure progress in a way that has a numerical value, and so I do feel like I could use this for all my students.